you do not want to hear virtual investigación clínica como América Latina. Me llamo Dasha Kristen.
My name is Dasha Kristen. I'm a member of statistics. I'm founder member of the initiative in Latin America for SWOG. I'm going to be the moderator of this panel with Javier Retamales from the Oncologic Collaborative Group for Research. I have some technical notes to share with you before starting the conference officially.
Desde un celular sin
If you're
aplicación.
joining from a cell phone without Zoom app, you will just have the audio, not the video. We advise you to use a computer or Zoom app in your phone. In case of any question to panel members, you can use the Q&A icon. You will just see your questions, not the questions of the rest of the people. If you have connectivity problems, please connect directly to the internet, or you can turn off and rejoin the meeting. Some presentations will be in English. If you want to listen English into Spanish, you have to press interpretation down below and choose the option Spanish. A disclaimer for interpretation: we are recording, and the purpose of interpretation services is to promote a better understanding of the conference, but this does not replace the original. No one or entity will take on responsibility for errors, omissions, or ambiguities in the interpretation provided during this conference. Now I'm going to give the floor to Dr. Bettina Müller from the National Cancer Institute in Chile and the coordinator for SWOG
Bueno, muchas gracias, Dacia.
Thank you very much,
Quiero
Dacia.
realmente darles la bienvenida
like
en nombre del equipo organizador aquí en Chile, a todos los que finalmente pudieron estar con nosotros. Este simposio costó un poco armarlo, ¿no es cierto? Los que estuvieron inscritos hace un año atrás, ¿no es cierto? Tuvieron que esperar un año para ver esto, pero finalmente lo pudimos hacer ahora sí en modalidad virtual por el tema del coronavirus. Quiero contarles nomás dos cositas acerca de quienes nos acompañan hoy día, ¿no es cierto? Bueno, tenemos un número grande de inscritos, 248 inscritos hasta este momento, en realidad de distintas partes de Latinoamérica y también de distintas partes de Chile, lo cual es la ventaja de hacerlo en forma virtual. Así que bienvenidos a todos los que ya están conectados. Y como ven, la gran mayoría son médicos o profesionales de la salud no médicos, pero también tenemos algunos participantes de distintas áreas, desde bioquímicos, biólogos, bioestadísticos, también data managers, bioinformáticos, así que vamos a tener una discusión, espero, muy provechosa con la incorporación de todas estas distintas visiones. Y por otro lado, también quiero realmente dar las gracias especialmente a la Fundación Hope, que está apoyando esto desde el punto de vista económico y también desde el punto de vista humano, ¿no es cierto?, con todas las personas de SWOG que nos están acompañando, y también a las instituciones que nos patrocinan aquí en Chile, que es el Colegio Médico, la Sociedad Chilena de Mastología, la Sociedad Chilena de Oncología Médica, la Sociedad de Cancerología y también el Instituto Nacional del Cáncer. Bueno, con eso paso la palabra al doctor Alejandro Moar para que nos dé también una bienvenida.
To welcome everyone. Thank you. And it is a pleasure to be here with all of you. It's been a tremendous effort that we have been making for some time to make this meeting possible. Before starting with the presentations on the program, I would like to point out 3 or 4 important points in this work. Number one, the tireless effort of our Chilean colleagues, because on 3 occasions we weren't unable, but now we can be together, although virtually. We're going to be working the whole week. And the other point is the fact, well, this was already mentioned by Dr. Mueller, which is the unconditional support given by SWOG, the Hope Foundation. Crab, Dr. Crowley has been someone helping us all the time so as to be able to be all of us together today, and taking the opportunity and the last days experienced by the planet due to the election in the US. I would like to congratulate the Americans. United States is one of the pillars of the Americas, and we're so happy that the dialogue and was able to be successful. So we would like to congratulate all of our colleagues from the United States for this great process that we saw on TV worldwide. And finally, what is the purpose of this meeting and what is the interest of being here? Well, after so many meetings we have held in the city of Mexico, in Bogota, and now in Santiago, Chile, we wanted to make an analysis, a reflection to see where we stand, what else we can do, and how we can do it together. Because I am convinced that with this very long effort of SWOG Latin America, I think we should be able to join efforts and start a second stage with our active participation in protocols summoned by SWOG, but also in protocols proposed by Latin America. And I think this is part of the program we're going to see today. Besides the wonderful presentations that are in the program, a comprehensive approach of cancer in Latin America, in the United States, the different opportunities for research, and some specific sections on the different projects. And as Dr. Crowley said, we can choose a champion for this project, so that Latin America and this group of countries that are part of this initiative are able to propose an original project inherent to the disease that we deal with. And this is one of the objectives of these 5 days, where we're going to share the different concerns and interests. Once again, I would like to thank you for being here, all of you from Latin America, because this is an opportunity for all of us. I think despite COVID limitations, now we have a much better opportunity for everyone to listen, to learn, to participate in the initiative of SWOG for Latin America. And I hope we can keep collaborating as we have done, strengthening clinical research in oncology throughout Latin America. Thank you very much. And with this, I think we can start with the first presentation. And a big hug to everyone from Mexico City. Thank you.
Para la apertura de este simposio,
in order to open this symposium, we have Dr. Maria Constanza Camargo. She's epidemiologist of cancer. She's from Colombia. She's a researcher in the Stedman program in genetics and epidemiology of cancer in NCI. This program is centered on H. pylori and gastric lesions, and she does squamous cell carcinoma in the esophagus and the potential etiological aspect of diseases. Her program combines studies of cancer and causality with projects that can have a transnational application for prevention of cancer and its treatment. We welcome Dr. Maria Constanza Camargo. Thank you very much. It's a pleasure to be with you this morning or afternoon. That all depends where you are. I'm going to make a presentation about the cancer burden in Latin America. I'm going to expand also on the national programs in Latin American countries. I'm going to speak about statistics for research. By way of introduction, Latin America and the Caribbean include 20 countries, 14 dependencies, 655 million people. That is the estimation for 2020, a very heterogeneous population given its history of migrations. 80% of the Latin American population lives in urban areas, and the GDP combined of the region is about $5.6 trillion, which is about 25% of the GDP of the United States. As it is shown by the pyramid, Latin America is a young region. The median age is 31 years old. I have no access to the presentation from here. Next one, the pyramid. Thank you. As you can see here in the pyramid, this is a young population. Life expectancy in the region is over the global expectancy. The life expectancy in women is 79 years old and men 73 years old. Next, please. In the next slide, we have the map of cancer incidence in the world based on the data of WHO for 2018. As you see, the incidence of cancer in Latin America is intermediate if we compare it with other countries. The rates are over 100 per 100,000 inhabitants. According to the forecast for 2030, we will see a substantial increase of cancer in the region, 35% of increase in South American countries and 42% in Central America and Mexico. For 2018, it was estimated new cases, 1.4 million. Next one, please. Thank you. About 680,000 cases were diagnosed in men and 730,000 in females. The main types of cancer in males are prostate, colon and rectum, lung and stomach. And in females, breast cancer, colorectal cancer, cervical cancer, and thyroid cancer are the main ones.
The next one too.
Next one. In this slide, I have a combination of data of mortality and incidence. Incidence in blue and mortality in red. As you can see, for mortality, cancer is the second cause of death in the region. These are data for 2018, ages 25 to 80 years old. As you see, the mortality or the cancers, the most fatal cancers are breast cancer, prostate, colon and rectum, lung cancer, cervical cancer, and stomach cancer. Next, please. In this table, I'm summarizing the main types of cancer for some of the Latin American countries. Here we have a mix of the types of cancer that affect developed populations, such as the US, Canada, and some European countries. And we have a combination of cancer associated to infection, particularly stomach and cervix. Next, please. This is a representation of the burdens attributable to excess body mass index and infection, excess of weight on the left in Chile, Uruguay, Mexico. We see that the percentage is higher for cancers associated to excessive body mass index and obesity. But cancers associated to infection are mostly focused on Bolivia, Peru, Venezuela, and some countries in Central America, particularly Guatemala, El Salvador, and Nicaragua. And this proportion can be more than 30%. Next one. One of the most vulnerable groups in Latin America are indigenous groups. It is estimated that there are about 60 million of indigenous people in the region that belong to more than 400 different groups. Cancers that affect them the most are associated to infections, cervical cancer, liver cancer, and gastric cancers. Those indigenous populations are quite exposed to different environmental carcinogens. Next, please. The epidemiological data for cancer in the region come from mortality registries and a limited number of population-based registries. This map was taken from the paper by Dr. Piñeiros, which shows that right now, well, there are only two registries with nationwide coverage, the one of Costa Rica and the other one of Uruguay. There are other areas with good registries, but keep being regional. In an effort to try and expand population registries in the region, WHO established a center in Argentina since 2013. The idea is for this center to be a facilitator to expand new registries for the incidence in the region. Next one. Now, regarding prevention and cancer control strategies in Latin America, this is a summary table from a Foreman and Sierra paper. In general, Latin American countries have a certain kind of programs to control cancer. This was since the year 2000, but the implementation of those programs has been just partial. And some of them include differentially the main risk factors for cancer, such as smoking, alcohol, obesity, physical activity, and inappropriate diet. This is one of the main risks for cancer, smoking. Here we see that we have about 70 million people that smoke. Next one. And those 70 million smokers in the region are equivalent to a cost of $34 billion a year in direct costs for health. This is a representation of the prevalence of the smoking for the year 2000, 2010, and the forecast for 2025. In the blue gradient, we have the estimation for adults, and for youngsters in green. The prevalence of smoking has declined over time. It is expected to keep dropping. There are efforts to control smoking in the region. However, about 50% of Latin American countries have prevalence of smoking over 25%, which is shown by the red line. In terms of alcohol, another important risk factor. Well, in this slide, we have the prevalence of alcohol for consumption in the last 12 months or excessive alcohol consumption. Next one.
Next slide, please.
Gracias. Entonces, esta es prevalencia de alcohol. Por favor, enfocarse en las barras rojas que muestran prevalencia.
Prevalence of alcohol. This is the prevalence in males and females according to this publication of PAHO for 2020. The prevalence of alcohol, which affects Latin America, those affected the most are Uruguay, Chile, and Argentina, with prevalence over 40%. And what we see is that the prevalence of females is even higher than the one of males. As far as trends over time, this report shows a comparison of consumption for the year 2010 versus 2016. As you see, there is an increase, which is not so big, but there is a significant increase in consumption of alcohol when comparing both years. Next, please. One of the exposures that affect not only Latin America and the world is the excess weight and obesity. In those figures, we see the prevalence for the year 1980 versus 2014. 1980, brown bars, 2014, orange bars. In the upper part, we have Caribbean, Middle America, South America, men, women, and there is a substantial increase in obesity. Countries with the highest degree of obesity are Mexico, 37.5%, Panama, Paraguay, Venezuela, and Chile. As you know, the obesity is associated to more than 10 different types of cancer. So this is of tremendous concern. And we think that the new cases we see of cancer in young persons are associated to obesity somehow. Next, a variable related to excess weight is physical activity. This is a figure from a paper published in 2018 that shows prevalence of insufficient physical activity in 2016, which was defined as less than 150 minutes of exercise, moderate or intensive exercise of 75, vigorous exercise a week. The prevalence in men is 34%, and in women is much higher, 44%. As you see, in some countries such as Brazil, there is more than 50%. Next, please. Regarding stomach cancer, here we have salt intake. These are the standardized means for the years 90 and 2010. 90 is the solid line, 2010 is the dotted line. All of the countries in the world have salt intake higher than what is recommended by scientific societies. The countries with the highest consumption are those in Central Asia and also high-income countries in Asia, Japan, Korea mostly, and this coincides with the high incidence of stomach cancer they have in Latin America. We have an intermediate consumption as compared to other countries in the world, but keeps being very high. It hasn't changed in the last 20 years. Next, please. Regarding lung cancer, we have meat consumption, which is high in the region, and it is believed that it will continue to grow. Next, please. As far as colorectal cancer, we have screening, appropriate screening test. We have occult blood colonoscopy, but around 50% of the Latin American countries have a screening for colon cancer in guidelines for management and control of cancer. Unfortunately, those programs are opportunistic and the coverage is less than what should be desired. In terms of cervical cancer, we have this figure from a recently published paper in JAMA. Next, please, which shows the prevalence of cervical cancer screening among women. There is a combination of different surveys between 2005 and 2017. There is a variable prevalence in the region with figures as low as 12% in Haiti, 23% in Guyana, in Bolivia, 47%. Next, please. This is correlated to the data from PAHO in relation to screening coverage, where only Brazil exceeds the goal of coverage above 70%. Next, please. For cervical cancer, we have a vaccine that is very effective that helps do primary prevention. This is the representation on the evolution of the vaccine and how it was adopted in Latin American countries. In 2006, we started in Puerto Rico adopting vaccination in girls, and the most recent countries, 2020, Costa Rica and El Salvador, they are now providing vaccination. Venezuela and Nicaragua are the only countries that do not have immunization programs as part of their healthcare programs for cancer. The number of doses given between 2015 and 2018, according to WHO, are approximately 69 million. We are still below expectation, but we are on the right track because all of the countries have included vaccination in their healthcare programs. Next, please. Now, switching gears, this is a representation of the number of radiologists and clinical oncologists per 100,000 inhabitants in Latin American countries. As you see, unfortunately, we have a lack of medical staff that is specialized in oncology to take care of the growing demand for cancer. Down below, there are absolute numbers according to the global survey that was published in 2018. Absolute number of clinical oncologists in Brazil. Brazil is the country that has the highest number of oncologists, 2,557, but it is not enough. As you see, the rates are very low. Next one, please. So cancer is a growing challenge in Latin America for many reasons. Number one, because life expectancies keep on the rise in the region. There is a demographic transition to risk factors associated to cancer. There is a 50% of the population in the region that has little or no access to health care. Preventive medicine is missing. There is lack of well-trained human resources, well-trained on oncology. There are uneven distribution of human resources, inequalities in health. There is poor access, especially for indigenous populations, to screening. Most patients seek treatment at advanced stages of the disease, so the survival is quite low. Regarding resources, they are limited. We know many of the medications are very expensive. So besides the cost limitation, there is a limitation in the number of drugs that reach the lesion. According to the Global Cancer Institute, between 2009 and 2013, for the whole world, there was availability of 39 new cancer drugs. In Mexico, only 17 arrived. In Brazil, only 10 arrived. But another thing that is very important is the lack of research, clinical and epidemiological research to document and help in this challenge. Next, please. How can we meet these challenges? And maybe the most important thing is this organized, multidisciplinary, intersectoral, interregional effort, such as what we're doing, sharing knowledge between countries, between regions, allowing us to take good experiences and use them in other countries. We need a more sustained investment in public health, education, training for health professionals in oncology. We have to emphasize primary prevention, promote healthy lifestyles. It's estimated that 40% of the cancer burden in Latin America could be reduced if we change the lifestyle. We have to strengthen advocacy, patient groups, and have more innovation in technology and in the social aspect. PAHO is doing a very important job trying to strengthen healthcare systems in the region. In that sense, the international community is not indifferent. As you might remember, in 2017, The Economist published areas on which we have to work. There were meetings, follow-up meetings after that. Next one, please. Next and next, there were major efforts. The most recent one is the Initiative for Integrated Cancer Control. The next one, please. This is a study of the healthcare systems in Argentina, Brazil, Chile, and Colombia. Documents for Argentina have been published, and we hope this is an example for other countries in the region. Next one. I would like to call the attention of this new document that published a position paper published by SLACOM, offering recommendations for governments and healthcare systems for how to take measures after the pandemic. Now, I'm going to change the subject on this. Latin America keeps contributing. Next one, please. Latin America keeps contributing about 5%. And this is because of the lack of dedicated researchers. Argentina is the country with the highest number of researchers per 1,000. As you see, numbers are bigger in other regions. Next one, please. According to the report of UNESCO 2015, Chile is the country with the largest number of publications, 350 in the year 2014, followed by Uruguay, Argentina, and Brazil. And the next one, the number of publications doesn't correlate with the number of citations. The countries with the highest number of citations are Bolivia, Costa Rica, Ecuador, Panama, and Peru. There are international collaborations that focus their attention, international collaborations, particularly with the United States. Brazil, Argentina keep being on the lead in the region. So there is a lot of room for improvement. This keeps being an important problem, cancer in Latin America. And as I said, figures will increase. Next one, please. Just as a way of motivation, I will leave you with what Henry Ford said. Coming together is a beginning. Keeping together is progress. Working together is success. So I call upon you to keep working together and forging collaboration that allows us to move forward for control and prevention of cancer in the Americas. Thank you very much for your attention.
Muchas gracias.
Thank you very much. I don't know if you can see me now. Yes. Thank you. All right. Now we're going to go to the next presentation by Dr. Elena Martinez. Dr. Martinez has a master's degree in public health and PhD in epidemiology. She is professor of the Department of Family Medicine and Public Health at the University of California, San Diego. She's specialty in disparities in cancer. She has ample experience leading and coordinating national and international projects for research. Her current work is focused on breast cancer, colorectal cancer, and GI tract cancer.
Thank you very much. Good morning or good afternoon to all of you. Can you see my screen? Okay, then. It is a pleasure to be with you. I hope we will be able to have a meeting in person soon. This presentation will focus on epidemiological data that will give us an idea of the cancer burden in the United States in Hispanics. I will showing data of incidence, survival, and also data comparing Hispanics born and not born in the United States. Very interesting, the information. I will also speak a little bit about data published more recently, which allows us to learn about the differences within the Hispanic group, comparing the different subgroups. And finally, I will speak a little bit about cancer in Native Americans in the United States. Well, let us start with this graph. Here we have data on the prevalence of cancer and mortality in Hispanics in the United States. In males, you have the data there, and females. The most common cancers like prostate, colon and rectum, lung, breast are also the most common in other populations, like Anglo-Saxons. But we can also see that in the Hispanics, we see cancers like liver, stomach, cervix, in female that are less common in Anglo-Saxons. I will speak more about that in another slide. In this graph, we can see the trends in incidence rates for cancer during 1992 to 2015. In males, we can see a decrease in prostate cancer, and also we can see an increase in the rates of liver cancer. In female, breast cancer continues to be more or less equal as a trend. but uterine cancer is increasing in the United States. And here we have the rates of mortality in males. You see there is a decrease in lung and prostate cancer, but we can also see there is an increase in liver cancer. In females, we see a drop in breast cancer and also a little bit in colorectal cancer. Just as in males, we can see an increase in liver cancers in females. I will speak a little bit about that also afterwards. Even so, this graph shows us that the incidence and mortality rates are lower in Hispanic males and females than in Anglo-Saxons, even though you can see minor differences in 2015 compared to previous years, like 1992, between Hispanics and Anglo-Saxons. So before we used to have bigger differences, and now we see that these differences are decreasing. Another statistical index that we can assess is cancer survival rates, looking at the differences between Hispanics and Anglo-Saxons. For most cancers, as we can see here, the incidence seems to be higher in Anglo-Saxon than Hispanic patients, with the exception of gallbladder cancer in females and males, and liver, lung, cervical cancer in female. There we see a lower survival in Hispanics. Now, let us go on to differences within the Hispanic group. I think we can learn very much from this data. And I'm glad that much of this information has been published recently. We know very well that we have a very varied population in the United States representing different countries. Well, the last election has underscored the differences. The Hispanics don't think like other populations. So we have to continue to appreciate these differences and this diversity. And it shouldn't be surprising to see these differences. But they haven't been noticed until recently. This graph shows death rates due to cancer in Mexican, Puerto Rican, Cuban descent Hispanics, and we have Anglo-Saxons for comparison purposes in orange. Let us see. For breast cancer, the lowest rate is 15. Cubans are higher, not very far from Anglo-Saxons. For colorectal cancer, the differences are very slight and not very different from Anglo-Saxons. Lung cancer, here we see something different. Bigger differences within the Hispanic groups, but much lower than Anglo-Saxons. And finally, for prostate, we don't have such big differences. Now, let us look at another group of cancers, those that have an infectious cause, which have a higher burden in Hispanics and Anglo-Saxons. Let us start with liver cancer. The highest burden is in Mexicans and Puerto Ricans. For stomach cancer, we also see something similar. And for cervix and uterine cancer, it's higher in Puerto Rican women. Let's go on to a subject that is becoming more important in the United States, and this is colorectal cancer in young persons under 50 years of age. Let us see here to the left that the rates of incidence in the United States for this cancer have been dropping for 1 or 2 decades in non-Hispanic whites, in Asians, and also in Hispanics. But when we look at these rates, In those under 50 years of age, we see the contrary. There is an increase in the incidence, and this increase can be seen in all the groups, even in Anglo-Saxons. The research in this area has increased very much in the United States to try to help us understand the reason why. In the meanwhile, even though there's no clarity, but in the meanwhile, in the United States, several official recommendations have been made to start an early detection and screening to prevent this cancer. Originally, it started at 50 years, but now the recommendation is 45, and much is due to this data. Now, let us review the mortality rates between Hispanics born in the United States and those that are not born in the United States. Here I present the data for female, and I also include the Anglo-Saxon population. For liver cancer, we do not see much difference between the Hispanic groups. A little bit more for stomach cancer, even though it's the opposite as in liver, so the mortality is higher in individuals born outside of the United States and those born in the United States. Something slighter for cervical and uterine cancer, but look at the difference for breast cancer. Much higher rates for females born in the United States and those born outside of the United States. Let us see now the data for males, which are the differences. Remember, I mentioned in the previous slide that for liver cancer, we didn't see much difference between US-born and foreign-born females. Look, for men, for males, it is an enormous difference. For stomach cancer, we see the opposite. And for kidney cancer, the rates are higher for US-born males. Same thing for colorectal cancer. So here we can appreciate these differences between the groups, and there are important variations for the different types of cancer. And data continue to be published. This manuscript was published last year, published by some colleagues, and they were wondering, where are the data for Central and South America? Well, here they are. Even though the number of cases for some cancers like stomach, pancreas, sometimes is very low and doesn't appear for certain Hispanic groups, as we see here. We see here Central Americans and South Americans have lower rates of mortality than other groups for lung, colorectal, and prostate cancer. For liver cancer, it's more or less the same. We do not see rates that are very high or low. And here we have the data for females. We can see that in patients from Central and South America, lung and colorectal rates are lower. Breast cancer is almost equal to the other groups. One could say that combining Central and South Americans is not appropriate, and maybe it is not, but I'm afraid that we do not have sufficient number of cases to be able to separate. So we will have to wait until we have more data to try to understand these differences in more depth. Finally, I would like to mention the changes that we have seen in the last 15 years in the increase of incidence of liver cancer in the United States. I show you these rates for males and females, Hispanics and Anglo-Saxons. Even though you can see an increase in both groups, the burden is higher for Hispanics. Research in this area has also increased a lot. Here we have a summary of the data for Hispanics, which I won't repeat to save some time. I will just tell you that we still have a long way to go to understand the burden of cancer in Hispanics in the United States. We need more data. We're a diverse group, but we do have some clarity regarding some cancers, like liver cancer is a very important problem in our population, and we need to continue to tackle that cancer. Let us go now to a short presentation on cancer in US Native Americans. It is short because we do not have much data. Like in the case of Hispanics, there's also a lot of diversity in this population in the United States. This diversity is divided by regions, as you can see, as this map shows. Populations can be divided into 5 regions in the area of the United States, but also Alaska. So we have 6 different groups in all. Taking into account these regions, here we can see the differences in cancer rates, death rates in females and males. Generally speaking, rates are lower in Arizona, for instance, whereas in the northern population and Alaska, the rates are higher. I want you to see that many of the native groups, the rates of mortality are higher than the overall rates for the United States that appear here in orange. So there are several groups, there are several regions of native populations that have death rates that are higher than the rest of the whole of the United States. And cancer in native populations is a research area that has also grown a lot because we haven't had much fund to study this very important area. So we see a lot of disparities here. Let's see one example using this data and this division by regions for gastric cancer death rates. In females, the highest rates are for Alaska and the lowest to the east of the country. Likewise, in males, the highest rates are found in Alaska. But we can also see that the southern west population also has quite high rates. 5 minutes left. And even though I would like to share similar data for native populations of Latin America, unfortunately, we do not have much epidemiological data. Already we heard a brief summary about this, but I would just like to request that more data be collected in this field. And just a comment and a summary. Cancer is #1 cause of death in Hispanics in the United States, but the most common cancers are lower in Hispanics and Anglo-Saxon. We see the contrary for infectious cause cancers. For several cancers, the rates in Hispanics born in the US are higher than those foreign born. Very little by national data comparing rates between US Hispanics and their country of origin. There are many opportunities to understand the burden of cancer in the Hispanic population. Finally, I would like to say once again, as I have said in other presentations, that collaboration between the United States and Latin American countries can help very much all the countries to move forward and stop this burden or decrease this burden in our countries. Thank you to SWOC for inviting me. Thank you for your attention, and I apologize because I won't be able to stay. I have to participate on an online meeting, a consortium meeting organized by the Cancerology Organization of the United States.
Agradecemos la participación de la
We
doctora
thank
Martínez.
the participation of Dr. Martinez. Before going to the last presentation of this block, we have available Q&A for those who are shy. Questions are not published until they're answered, so you can upload all of the questions. Now, regarding the last presentation, Dr. Carolina Wisner, Director of the National Institute of Cancerology in Colombia, Master's degree in Public Health, University of Tokyo, candidacy for PhD, Social Studies in Colombia, with many publications on cervical cancer, screening, HPV vaccine, public health, inequities, and registries. We welcome Dr. Carolina Wisner. Good afternoon to everyone, or good morning. I would like to thank SWA Group. My greetings to Dr. Bettina, Dr. Alejandro, and my greetings to all of the participants. I'm going to speak on the National Institutes of Cancer in Latin America and how, as being a director, we can strengthen research and trigger synergies. As an objective of this presentation, I'm going to describe the context of science, technology, and innovation to compare the different real or potential capabilities of National Institutes of Cancer vis-a-vis generation of knowledge. To do that, I've divided this presentation into 4 parts. I will tell you about the general context of this discussion, particularly in Colombia, which has created a framework to make a local transformation at our institute. I will tell you very briefly the history of the network of Institute of Cancer. Number 3, I'm going to present 2 brief results of a survey that we did among some of the members of the Latin American members, and I will close with conclusions and challenges to the future. I have to tell you that in Colombia, 2 years ago, after an initiative of the president's office, a group of experts was set up with a long experience in innovation and technology. The idea was that they gave recommendations to the new Ministry of Science and Technology that started in 2019 as a challenge to have an answer to those challenges. Within the framework of this discussion and academic gatherings, a publication was made. This is the picture of Focus on Health, and we had the possibility to discuss 3 frameworks of innovation policies that I thought were very important from the proposal we've been working on from Latin American countries. I'm going to take the opportunity to summarize in a few slides these models of policies for science, technology, and innovation based on the work by Johann Schott and Steinmüller. With this, I was able to discuss on public institutes of research. Next, please. According to the authors, there are 3 models. The first one was set up in the decade of 50s, which was innovation for growth. The second one was configured in the 80s, and it was called National Innovation Systems. And the last one is of the decade of the 90s, which is called Transformative Innovation. They've had a sequential order, but they are present in the ideas of the politicians. I'm going to speak about each one of them. Next, please. The first one is called Innovation for Growth. And according to Dr. Short and Steinmuller, this was created after the Cold War, when all of the states had to respond to the needs for economic growth. And during that period, there was no doubt about the important role of the state, because you had to transform the industry to scientifically based industries to guarantee productivity. The big investments were made, which were important in Europe and the United States, but very little in Latin America. And this investment was made in the military strategies, communication strategies, and transportation. And they were very important during this period. Next one. But it was evident for medium-income countries that this catch-up of technology was very difficult if there were no local conditions allowing them to exist. So in the 80s, we have the globalization of the market, and it was evident that it was necessary to expand the competitive advantage and favor domestic companies. In the 80s, there was a reduction of the public expense, and there was less strengthening of public institute to open a big space to the private sector and generate protection for the intellectual property. In this model, there is a consolidation not only of the development of the state, the vision of the state is reduced, there is more development of companies, and there is more research at universities. And so here we have the triple helix model, university, enterprise, state. And the last model, which started to gain importance, is transformative innovation. It has had an impact on the Colombian context. It has been assimilated by the Ministry of Science. And there are some criticisms to the previous models, because it is necessary to measure the negative impact in the context of equity. And it is proposed to make changes in the practices, infrastructures. So now we are at the transformative innovation system. And so the idea is to promote more governance between the state, the market, the civil society, and science. Within this innovation project, emphasis is made on interinstitutional collaboration and working in networks. I think we are lagging behind with the slides. Thank you very much. Parallel to this reflection on the models of policy in science, technology, innovation, the OECD, Colombia is already part of it. We had a Human Development Index middle low. Now we have a high index of human development. Now emphasis is made, as in the 80s and 90s, in the public institutes of innovation. Those institutes, from the year 2000, there is more historic importance. In this book on public research institutions, there is a recognition on a new political scenario where public research institutes should be defined as a strategy of the state. These publications have been very important because it has always been a permanent concern as a researcher and as participant of the National Institute of Cancerology. Has been a concern, the big barriers to do research and how these are structural situations that we should start transforming. OECD has some indicators that Dr. Camargo already mentioned, some of them. The percentage of the GDP that governments invest in research and development. And we see countries like Israel, the percentage is 4.9 of the GDP. United States, 2.8. And far below the average of OECD countries, we have Argentina, Chile, and Colombia, I think is at the lowest point as far as investment made by the state in research and development. And here we have the number of researchers. And Constanza has already mentioned this figure to highlight that Argentina and Chile are far below the average of countries of OECD. Next, please. And Colombia and Chile as well. Next, please. Okay, within the framework of this context, given the fact that National Institutes of Cancer are also research institutes, and almost 90% are public institutes that should be considered as strategic for the state, I will show you what RINC did, the Network of National Institute of Cancer, which was created by UNASUR, which is a geopolitical entity in the year 2011. Next, please. In the 5-year plan, 2010-2015, our INC had 4 specific strategies. These are the 2 that were important for research, such as population-based cancer registries. Constanza mentioned the weaknesses we had in the region, and in quality registries, it is quite difficult to do etiological research. And the other fundamental strategy was the creation and the possibility for biobanks of Latin America to get together. Next, please. And now we have Latin American countries that could have a spaces of discussion to standardize processes, procedures, and share experiences that could improve the quality of those biobanks. Colombia has already given samples of good quality to NCI and AYAC. So this shows the efficacy of those kinds of works where we can have the support and collaboration from the international community. In February 2015, next please, an analysis was made of the weaknesses of this network. I'm going to go very fast here. Weaknesses. The structure was political. We depended on UNASUR, which is political. Therefore, it was considered a fragile structure. Next, please. Opportunities. Well, we have a context and epidemiological priorities which are in common, and institutes, most of them are autonomous and depend from the Ministry of Health, but they have the possibility of providing this administrative structure. As far as strength, next please. No doubt, it was considered an important platform for collaboration and the possibility to articulate with other international agencies. One of the most important threats were the political differences between countries. Next, please. And of course, the fact that governments took turns. This threat became real, and in the year 2018, governments gave the instruction to RINC that we couldn't get together again because member countries had withdrawn from UNASUR. In this juncture, next please, the Institutes of Cancer wanted to give continuity to these strategies, so that given the fact that our institute is 85 years last year, we did this meeting of a network of cancer institutes to think about new strategies and keep collaborating. Next, please. In the agenda, we had the presence of the NCI, Dr. Edward Trimble, who highlighted some aspects that called my attention and you could make the correlation with the previous models. No doubt, since 1953, the NCI, which is research, had a program of clinical research. In 1973, the Cancer Institute recognized cancer centers in the country with which more research can be done. In 1989, there were grants for extramural research laboratories. In 1999, there were grants for the network of early detection and the SWOG network, which is being established in collaboration with Latin America. In that meeting we held, next please, last year, we did a comparative analysis of the National Cancer Institute of Latin America, with the exception of Argentina, which is the more modern. All of the cancer institutes were inaugurated in the 30s to include a technology such as radiotherapy. And thanks to the volume of patients that we have, it has become a center for human talent training. Largest institutes such as in Brazil, Mexico, and Peru, they play an important role in the policymaking and promotion of public health. And they produce research, and not everything is articulated in research networks. For example, Panama and Bolivia are not linked to research networks, and not all of the institutes, or at least during the reforms in the 90s, some institutes lost the possibility to make important proposals to control cancer in the country. And in that comparative analysis, next please, we see how the National Institute of Mexico has a differential salary factor for research based on production and the academic degree. Brazil recognizes the titles of PhD. Peru has a high number of research funded by the industry. And in Colombia, we do not have differential salary by research, by career, but the pharmaceutical industry provides additional significant remuneration. So, next, please. Here we see how in almost, well, according to what has been said, the United States has 24% of clinical trials dedicated to cancer. And that percentage, despite the number is quite low in Latin American countries, that number would be between 1% to 28%, as Peru mentioned, which has the largest number of clinical trials underway. We recently did a survey, next please, to see the proportion of active studies, and within active studies, the predominant topic. And there are 4 types of studies: populational, translational, molecular biology, and clinical trials. Most of the molecular biology studies are funded by their own resources. Next, please. And when we asked, well, these were 7 national institutes that responded to the survey that are part of the new network that is called INC-ALC. Now, before it was RINC, and now INC LATAM. Not 100% of the clinical trials are funded by the industry, but above 80%. All right, next, please. In the literature, we see publications about the barriers for research, clinical research in cancer institutes. And what we found is not different from what is already being said. The biggest barrier is funding, independent funding, time dedicated and career of the investigator, the human talent, because there is no specific training in research. National regulations are usually complex, and the opportunity is difficult. Human talent is trained, and they end up migrating to the private sector where they are paid more. Ethics committee meetings tend to be long. In some of the institutes, there is no career path, and there are difficulties in the infrastructure to generate research projects. When we ask, because next please, in the model of transformative relationship, there is network activities. These are the institutes that answer the survey. 3 belong to SWAG, 1 to ECOG, but we would expect this participation to be higher international networks. And according to the OECD, we should be clear about the reasons to have different degrees of internationalization, and in this way, to better mobilize the work in a network. And to close, some conclusions I would like to share with you. Within the transformative innovation model and in the guidelines given by OECD, the National Cancer Institute should overcome barriers and strengthen capacity to generate knowledge by modifying structure. The ring consolidated an important work as a network, but now becomes a new platform called INC LATAM. This new network structure, INC LATAM, expects to keep strengthening the work in research, and in the context of analysis of models and comparative analysis with the institutes allowed us, especially in Colombia, and now in the Congress, we have a bill trying to have institutional transformation where we are not essentially providers of healthcare services, but strengthen research to overcome barriers. And INC LATAM can be an important platform to strengthen the model and continue working as a network and continue to have synergies when doing collaborative work. Thank you very much for your attention, and thank you for the invitation. Thank you very much. Now we'll go to the round table. We have 27 minutes for the round table. If you have questions, you can write them using the icon question and answer. Javier, would you like to start the round table? Thank you very much to all of the speakers. Thank you, Daisha. I think now I pronounced it properly. One of the questions that are arriving, I am the moderator, and this is a question I wanted to ask a long time ago. What about the experience, your experience as researcher by establishing collaboration with Latin American sites, and what barriers should be somehow one get rid of to optimize this work? Thank you. I'm connected with a computer and phone because in one I have audio and the other one I don't have video. Well, thank you very much. I've been in the United States more than 1 decade, and I've always tried to encourage research in Latin America. I think a big limitation tackled by Carolina is the strengthening of biobanks. Technology in many of Latin American countries is limited, but I think we can do something if we start with samples. In the institute where I work, there is a lot of interest to close ties with Latin America, but there must be local interest by government, by local institutions. And the idea is to strengthen this collaborative work.
Muchas gracias.
Thank you very much. We have a question by Juan Carlos Araya. How the business model of clinical research linked to pharmaceutical companies is a barrier or an obstacle for scientific development in countries, cities, and universities with little economic resources.
Desde la experiencia de la doctora Wisner, podríamos...
Maybe Dr. Wisner could say something about that. I think the fact that we are participating in projects and clinical trials funded by the industry has had benefits, no doubt about it. Monitoring of quality protocols to guarantee validity of data, to verify safety of patients. All of this has established an infrastructure, a culture, which allowed to strengthen this culture in all of those spaces where it is needed to do quality research. I have no doubts that this should continue. We have to keep working. But I do not, I think the fact of knowing the structure of SWOG that promotes independent research of the industry, we have started to learn how this is possible and the effort it implies, where incentives not only economic but of other kind can provide also the possibility of responding to the specific issues of clinical researchers. I don't think this is incompatible, but given the fact that in Latin America, we have focused on developing projects funded by the industry, which are so important because of our infrastructure to maintain human talent, and that human talent is not working in two or more places, that they can have more time. For me, it is fundamental. And the current structure allows us to have the necessary tools to produce incentives and be able to define the new model to work. Thank you. Another question we received is that where do you think lies the highest need for training? Because there is professional training and also research training. Where do you think training is needed the most? Are there university programs underway to do something about it? Constanza, maybe you can start. I will start. I think that right now, given the growing incidence of cancer, we have to work in every front. We have to train medical staff, and I understand that ASCO has made a lot of effort trying to expand oncological training, and they would like to have a discipline which is a sort of global oncology. As far as human resources, we have to emphasize research. We have to be able to reach patients, how to remove barriers for participation in clinical trials, epidemiological studies. I think this is a multidisciplinary work, multi-domain work. I think we have to move forward in every front, really. All right, I agree. And I think in Latin American countries, less than a decade ago, were given importance to infectious diseases. That was predominant at the time. And just quite recently, visibility was given to cancer as a problem of public health, when it was already the second or third cause of death. Other communicable diseases were more important. So the training of human talent, undergraduate, postgraduate, revolved around communicable diseases. And we all know that cancer is another paradigm, even In the models of epidemiological surveillance, cancer is not the same as communicable diseases, and more training was needed. So the Institute of Cancerology promoted a PhD in oncology at the National University to have human talent that could dedicate to research. But if all of those resources are trained, but there is no structure allowing to keep that human talent, usually they could work in different fields. So the thing is the structure that we can give to it so that the state provides the necessary incentives.
Gracias. Una pregunta de Dr. Alejandro Corbalán para la doctora Camargo.
Now, Dr. Camargo, in the context of cancer at a young age, what is the situation of familial hereditary cancer? Traditionally, the cases diagnosed early in terms of age were considered to be hereditary mostly. But we see in the United States and other populations an advent of cancer at younger ages. This is not oriented to genomics because genes have not changed, but the environment has changed very abruptly in the last decades. In the US, we see, as Dr. Martinez said, we see an increase in colorectal cancer. There is an increase in stomach cancer. It was just seen in the minorities, but now we see an increase in the rates of cancer in white people, non-Hispanic. That was a surprise. We see an increase in lung cancer. There are about 10 types of cancer that are now associated to younger ages. We believe that this is related to the changes in the lifestyle, obesity, antibiotics, changes in the gastric microbiota. We understand that microbiota is also an organ in the body. There is a sort of disruption that we have made that is affecting negatively the population. We still have cancers early, but there is a new group of sporadic cancers that happen early, and we have to pay a lot of attention to them. Thank you very much. Thank you very much for the answer. I'm still receiving a lot of questions. I can't see them all, but a question that has appeared several times regarding Hispanic cancer rate, if there is any relationship with the rates in Spain. In Spain? Yes. The question is, the rate of cancer in Hispanics in the US, is it related to the rates of cancer in Spain?
I haven't seen a specific comparison with European countries. Generally, it's Hispanics and Hispanic or non-Hispanics in the United States, but in Spain, patterns are similar to other developed countries in Europe. At least for stomach cancer, you can find some specific groups in Spain that are affected, colorectal cancer with similar patterns. But in the United States, for those Hispanics living in the United States, there's a transition to a profile that is more similar to white non-Hispanics. But we have a change of being a little bit more developed in the Southern Cone versus those who still have a very high burden of cancers associated to infections.
The question, I think the question is more for Dr. Wisner, but maybe Dr. Camargo can say something. The public health cancer care, if there has been a change?
Well, in Colombia, during the 20th century, our biggest priority has been cancers associated to infections. But as Constanza mentioned, fortunately, infection-related cancers have dropped. So at least in the field of cervix cancer, cervical cancers, the study from the Cancerology Institute have allowed to promote changes in the policies in healthcare guidelines, especially regarding screening, also regarding reduction of some risk factors like smoking. So yes, it is very important to be able to continue to develop research and to have in this way an impact upon public policies.
Thank you. Another question that we see here is, this is a question for both, because both of you have seen this from different views. One of you is from the Institute of Cancer and the other one in the field. The question is, what about biobanks samples from Latin America? How can you standardize biobanks? How can you work with biobanks in Latin America?
Well, as I said, the Ring platform showed that Latin American countries could have this kind of sample collection. When a researcher makes a decision that he needs a lot of time to collect a sufficient number of samples that will be a big sample size, enough of a sufficient size. And the network allowed, with the support of the NCI, to have similar standards and procedures. So in that sense, we've made a big investment from the National Cancer Institute of Colombia. Samples have been provided to the IARC and to projects where Dr. Constanzo Camargo is researching. So I would like to offer the floor to Dr. Camargo. Thank you, Carolina. Fortunately, for the cures of stomach cancer that we are doing, we established an alliance of Latin American countries, and we're very happy of being able to work together. The group that participated the most was the group of Brazil. They have a tradition of biobanks from many years, and they are an example from Latin America. We should have a greater transfer from them to the other Latin American countries. For that big project, we got the participation of Brazil, of Chile, of Peru, of Colombia, Honduras, Mexico, and we even have Hispanics in the United States. So it is one of the few UAS that we have been able to do. In this kind of population, most Hispanics are of Mexican origin, and they do not represent the genetic diversity of the region. Well, so little by little, we have made progress, but still the samples available in the biobanks are still small. And what would like to, besides the tumor, we had non-malignant tissue and a blood sample, but sometimes it's not complete. But anyway, this is progressive, and I think little by little we will materialize this. Carolina made an enormous effort when the NCI was working with another institute in the DCGA project. They tried to collaborate, but unfortunately, we were left out of many of the efforts. And most of the studies today represent populations, particularly non-Hispanic white populations. And to come to a personalized medicine, we have to invest much more to deploy more efforts in terms of sample collections, characterized samples, So little by little, we have been working, but we have to continue. But thank you to all the biobanks in Latin America that have supported it, and we benefit from samples from Dr. Corvalan, for instance, that had samples from previous studies of stomach cancer. So little by little, we will have some thousands. I think that little by little we will continue to combine samples and characterizing, featuring better the cancer, these kind of cancer patients in Latin America.
Now that we're speaking about biobanks and the good experience of collaboration, there is a question asked by an anonymous collaborator. In case of collaboration, do you think there are regulatory obstacles vis-a-vis transfer of samples? And as clinicians, there are non-physicians too. How can we support local stakeholders in terms of the regulatory aspect?
Yes, that is very important because it varies, and Carolina can discuss this also. In some countries, it is relatively easy to do the transfer, to sign the transfer agreements, to do research. In other countries, really, there's a little bit more bureaucracy for even repatriation of samples. Dr. Mojar here could speak about Mexico, what it means for Mexico to collaborate internationally. Sometimes it is difficult, so it would be good to explore the possibility of sample transfer policies between Latin American countries and maybe beyond, some more uniform policies, more better adapted to the reality that we are developing team science, and we need for a constant transfer of data and samples. We are very patient. Some centers have been more difficult than others, but we've been able to materialize all those collaborations.
Carolina, ¿podrías hablar sobre el caso de
Carolina,
could you tell us about the case of Colombia and biobanks? I think it's challenge biosamples from Colombia.
Yes, in Colombia, given the lack of experience in sending samples, we've had very specific experiences. It was a bureaucratic exercise to be able to export samples, but as we've been having more projects, a culture is developed and procedures are defined. But these bureaucratic structures are modified, can be modified when the staff changes. And that could be a network work to have a standard regulation and to give continuity to these things a long time.
Disculpe, estamos mirando las últimas preguntas.
We are checking the questions. Javier? A question that is also important. In the US, they have seen that the incidence and mortality varies according to population. Are there screenings focused or targeting specific populations?
Yes, in the United States, we have several screening programs. We see that there are inequalities in terms of the persons that are screened. The Hispanics are generally lagging behind. People are sort of afraid of going through a colonoscopy or occult blood test. There's also some delay in Latin American populations. They also have poorer coverages. And here I think we need to educate because people really do not understand the need to go through a screening in due time. Colonoscopy at 50 years, the first one, and there are windows afterwards to delay the next one. These more invasive procedures, people sometimes are more afraid. I think there's a lot of work to do in the sense of screening and in the sense of modifying risk factors. In the United States, in general terms, despite the limitations that we have in terms of health insurances and coverage, we have access. We do have access for cervical cancer, for vaccination also. Maybe those are the more important aspects.
Nos quedan los últimos 4 minutos, Deisha. No sé si alcanzamos a...
Last 4 minutes, Deisha. I don't know if we have time for another question.
Bueno, tal vez podrían hablarnos de su
Well,
experiencia.
you might tell us about your experience researching public health
¿Cómo puede ayudar a reducir las
and
desigualdades
how can
de cáncer en la región?
this reduce inequalities in cancer outcome?
Well, from our experience, one of the focuses of research have been those more prevalent pathologies, stomach cancer, cervical cancer, and populational studies where we have made visible, not only in the international context, but in the national context, the regional differences. And in this way, we can approach our interventions in public health in a better way. And for us, and I think that for most of cancer institutes, it has been very important to have the support of international agencies like the International Agency for Cancer Research, in all the research that leads us to promote different screening strategies. For instance, introducing BPH screening and other interventions like visual description techniques. Well, we have many obstacles for the implementation of this, but at least we can participate in research, and that is something that helps us implement policies in the country.
Muy bien. La doctora Camargo, ¿tendría algo para...
Dr. Camargo, would you like to add something?
I think that in Latin America, we still have to be a little bit more creative regarding research because resources are always restricted. I can speak about the experience with a group of collaborators that I have in Chile, headed by Dr. Corvalan, in terms that we know that for stomach cancer, the incidence is very high in Japan, in Korea, in China, and somehow they have solved this problem. We are trying to see how we adapt all that experience, and we have thought, for instance, in campaigns to identify patients with intestinal neoplasia, which could be a precursor and could be followed in time. This would allow us to focus on risk populations because unfortunately the situation of Latin America in stomach cancer still has a very high mortality. So for each specific cancer, we have to see how we can make progress with the budget restrictions, with the inherent limitations that we have. How can we adapt low-cost strategies that will allow us to somehow modify the mortality and incidence trends? I think that we have a region that is full of talent, and somehow we have to benefit from that and see how we can work together to mobilize resources and exchange ideas and change the situation. Thank you very much.
Thank you very much to the participants in the roundtable and the audience for the questions. Before going to a 20-minute break, please answer a poll before leaving the meeting.
Creo que todos pueden ver.
I think everyone can see the poll. We will resume in 20 minutes at 6 Chilean time.
Muchas gracias.
Thank you.